when we go to question and answers, I know the formula, for really looking at the members of the committee first. I'm hoping that there will be time for people like Michael Valaire to share some initiatives that he's been working on for quite some time with elders. I'm hoping there'll be time for people like Cindy Brock to reflect a little bit, because she's one of the first people who brought this topic to the table at the Health Literacy Roundtable, to see if this met the needs and vision that you had, and for many others, of course, and I'll try my best to call on you in order of those wonderful cards going up. So Kim Parsons had put her name card up really early and is eager to make a comment.
Shocking everyone in the room. Thank you so much, panel. And so as I was listening to you, one of the things that I thought about, and Susan, maybe you'll be able to speak to this maybe with with the many interviews that you've done. But so I'd like to ask you all to talk a little bit more about depression and the impact of depression, and maybe what are some of the impacts that you see on people's lives that may be feeding or adding to that depression. So.
That was one of my points here that I didn't get to, so thank you very much. A couple of the women who, from my point of view, seem very, very high functioning said to me, I do get the blues, or I do get sad. And these women do have strategies for themselves. One says she literally, when she can't get out of bed, she just kicks out and says, enough of that, you got to get out of bed. Another one takes a walk. But these are the women who have the insight about depression and are acting on it. And so I really agree with you. There's probably a lot more depression. And people they're not saying it. And if they're not saying it, then the health provider isn't recognizing it as either. And whether you're living at home or living in senior housing, you can be very alone. And one of the women said to me, I keep wondering, am I alone or am I lonely? And trying to understand even what that all means. I think it's enormous, and I agree with you. I think it's got to come out as something that people can discuss and deal with some strategies.
Thank you. And any other comments?
So I think it's almost a perfect storm, because once you reach a certain age, a high percentage of people are going to end up with chronic conditions, which then lends itself to be depressed. And then that will then impact on how well equipped you are to actually take care of yourself and to focus and concentrate and do the things that you need to do. And it has repercussions even beyond that. So, for example, if you are already depressed when you have an MI, you're much more likely to have a second MI. So these are not minor things. And then if you're already lonely, then it's more likely you're going to be depressed. If you're depressed and you withdraw, you're more likely to then get lonely. You can get into this whole big quagmire that then impacts, correlations of loneliness with diabetes, with stroke, etc. So I think that we have to get to your point where people are willing to ask the questions, and maybe it's not, are you depressed, because it may not resonate with that person, or they don't want to think of themselves as that way. But do you feel blue, or do you just feel down, they may respond to that. But if you don't ever ask the question in any kind of way, then it just becomes even more of a challenge for that person. And then that has further repercussions all the way down the line.
Let me offer a link to literacy as well, because with limited literacy, it also means that there might be limited opportunities for reading. And it's through reading that you accrue vocabulary. And vocabulary is needed to express those things that are not concrete. Even a physical symptom, I have a discomfort in here. You're trying to express that to someone you don't know very well, a doctor that you may see 4 times a year. This new sensation that I have in here. And imagine a new sensation that you have in your feelings, plus the fact that it's not normed properly to talk about certain things. You know, in many cultures, you don't say things like loneliness and isolation and sad and blue. These are silences. These are not things expressed. So that mixture of normative behavior and limited literacy skills through limited vocabulary, perhaps, can really exacerbate the problem of expressing your needs and expressing your feelings.
Well, and I think that if you have limited health literacy at a time that you're even more vulnerable, then you just become more isolated
Yes.
than you were before at a time that you need to be the least isolated of all. It just strikes me that for many people, at a time when a lot of things your life is getting more and more and more and more complicated in some ways, you're becoming less and less equipped to deal with it.
Okay. Marianne brought up the issue of phase 4 based on Dr. Thomas's statement about the need for phase 4. Can we think about addressing some questions in regard to what's the next step? What is it that health literacy focus can do to help this issue, to mitigate these pains, to increase greater access? Are there people from the roundtable? Oh, good.
Thanks very much, Shauna Koss again. It occurred to me, and I was worried before I came today, that it was going to be more academic research focused, and I was much relieved that most of the conversation was not that. But coming into this, I went back to a very simple model of how to evolve change, which is the PDSA, Plan, Do, Study, Act. And it strikes me that so much of this is community, family, individual oriented, that it lends itself to that smaller model of evaluation and change, that then our job would be to figure out a way to aggregate those activities and bring them to larger scale.
Systemic change.
Yeah.
Mm-hmm. Any other comments or questions from the roundtable? Michael, would you just share that initiative that you have underway?
Sure. Michael Valera, Institute for Healthcare Advancement. We're a healthcare nonprofit in North Orange County, California, medically underserved, very ethnically diverse city. But we've actually got a really great collaborative of a number of different broad-based groups that come together in service to the community. And these are faith-based groups, city, nonprofit, for-profit organizations that all come together and meet on a regular basis and work under 4 pillars of service. One of them is service to seniors. And so in that area, one of the things that a couple of things that we're doing, one of them is if you're all familiar with the Promotora model of community workers who live in the community and are part of that particular group, go into the community and seek out isolated seniors to kind of bring them back into the system. One of the things that we do as a nonprofit organization is write a series of self-help health books written at a 3rd to 5th grade level. One of those books is called What to Do for Senior Health. And so we've kind of built a resource kit around that. And in that kit is the book. We have an easy-to-read advanced directive form written by Rebecca Sidori, who many of you know from UC San Francisco. We have an exercise video that we've developed that improves strength, balance, and flexibility to help people reduce the likelihood of falling, and if they start to fall, that they can correct and catch themselves. Home safety assessment for fall risks. We've partnered with some service organizations to go into the homes and do remediation. So Home Depot has agreed to provide the grab bars and wiring and those sorts of things, and people from Rotary Club and other service organizations have agreed to go in and do those remediation. So And the Promotora does a series of interviews and works with the seniors to try and get them reconnected back into the community so that they can avail themselves of a lot of these sorts of services. We also have a week-long program called Senior Week, where we have a lot of senior health fair. We have a senior prom, a lot of different things that kind of just bring seniors together and allow them to take advantage of seniors, senior programs, senior services in the community. And then we're also doing a randomized controlled trial with some of the things that I mentioned in that senior kit to see if we can actually reduce the incidence of fall. And we're partnering with a dual eligibles managed care organization, so we have access to claims data, so we can actually follow that cohort for a couple of years. So we're interested in what sort of data that study will do.
Thank you, Michael. And Lori, I hadn't seen your card up. Sorry about that.
So we've spoken a lot today about the caregiver role and how there's tremendous stress as well as they're being relied on as a source of information, and they may themselves have significant misunderstandings. And they're typically brought into that role during times of crisis, during illness. And I guess my question for you is, how can, as a field of health literacy, what could we do to help to support caregivers to aid prevention and wellness? And I think, Michael, what you just talked about is kind of a really nice example of that. It was perfect setup. In my world, it's things like, vaccinations, but I think it's a much, much broader thing than that. And so I just welcome your thoughts on, what the field of health literacy can help to do to address supporting caregivers proactively.
And please take that question. I mean, people from the audience can answer that as well as people from the panel.
I think what's really important is for the recognition and the respect and the understanding of what's going on for a caregiver. I'm familiar with the Alzheimer's Association, and they do a lot of caregiver work. They have caregiver support groups. A number of people say they could not have gotten through caring for a family member with Alzheimer's if they didn't have those connections with other caregivers. So it's that recognition and also giving the opportunity for people to get together and talk out what some of these frustrations are.
One thing that we offer as a part of our ARP caregiving experience, and this is actually a request that came from a caregiver, are videos. So if you are in this role and you suddenly have to give sort of like different sort of medical treatments or different things like that, a lot of these caregivers, they don't know how to do this. So it really is showing them very step by step. If you have to, so someone's been in their bed for a while and you kind of have to move them around. I mean, it shows you like step by step how you do these things. And I think while definitely the community is a huge part, and you definitely need to make sure that the caregiver can ask those questions and feel like there's a safe space to have that kind of conversation, it is important to give them the skills and the tools they need so they aren't as stressed out. Like they won't be as stressed out about like, how do I do this? Oh, there's a video that very easily shows me how to do it.
Thank you. It's a distance, and I'm trying to make sure that I get your name right. Is it Lisa down at the end?
It is,
who has
yeah.
a card up? Thank you.
Thanks very much. Lisa Fitzpatrick. I'm a new member of the Round Table, and hopefully you all will get to know me as Dr. Lisa on the street, because I had an encounter with an elderly woman about a conversation she had with her doctor, and she told me her doctor told her she had prediabetes. And she asked me what that meant. So when I asked her, well, why didn't you ask your doctor what that meant? She said, he's a good doctor, but he's just really busy and I didn't want to bother him. So the first thing I thought was, she didn't know I was a doctor. I was a stranger to her, and she was asking me this question. How can community members be more engaged with older people who are living around them? To provide any information that they might know or help point them to resources. And then the second thing is I'm a little cynical about physicians and folks who are out in practice changing their behavior. We talked earlier about the universal precautions, but I don't see us seeing a huge uptake in that. But what about the people in the pipeline and whether or not they can help? So I didn't hear much about that today, but I would love to get your feedback about the community supports and then what we can do to train young people to think about this. Because I've sort of given up on my generation and the older.
Oh, dear. Some comments from the panel?
Well,
Marianne?
There are some that are in between you and me that somehow figured it out, and my doctors aren't all perfect, but somehow within that, I don't know if they've been in more teaching hospitals or what, but the asking questions and listening and sort of being honest. Somebody mentioned about a doctor that admitted making a mistake. I have found that as I've gotten to know some of my doctors, they have sort of talked out loud about some of their decision processes and sort of wondering a little bit how they got to wherever. And to me, it's gut feel, but it was the right gut feel. And so we're talking often much more as equals rather than separate. There are other doctors I've had that certainly don't fit that mold, but so there's something that's going on in education and or temperament, because some of the doctors I'm talking about are probably around 55 to 40 in that age range, that have done really well in that kind of communication.
But I just say, I was listening to you talk about your doctors, and I felt like they were outliers. You got lucky.
And I'll take that. Fine with me, and I hope others can share.
Well, and I think there's a huge opportunity with the AAMC, kind of to your point, to get this embedded from the very, very beginning. So it's not like some separate conversation that you're having. It's just part and parcel of what you learn as a medical student or any other healthcare professional, and it's an expectation. I think that kind of at the other end of the spectrum, that there will probably be some people who will change because of the way that reimbursement is changing in terms of value-based, because when the focus is on really having great outcomes, it becomes more difficult to have great outcomes if you've got health literacy issues or you know nothing about it. And I also think that it's a scenario that the more that you work on the health literacy of your patients, to what I think it was Dr. Thomas had said, the more it feels like you've gotten back to what you really wanted to do in terms of taking care of patients and bringing more of the joy in, because the physicians are also burning out because they aren't feeling those warm and fuzzy feelings because of everything else that's going on in the system.
Jay, and then Steve, and then Michael, and then I'm going to be turning the podium over to you for the closing. Okay.
Thank you. Jay Duig with the Roundtable. That was from the provider perspective of how we can encourage those behaviors. From the other parts of the healthcare system, specifically in manufacturers, in those building stuff that we need to use. So how can we encourage, how can health literacy encourage or even incentivize a similar level of engagement and focus on older adults? Because what you each described, a lot of me, when I think about it from, like a design perspective, you hear things. Ms. Taylor Brigoni, when you said about like human error, so the design perspective is to think in terms of use error, that's more of a system, that, that this is actually systemic error that can be addressed. Or when you were talking about, Ms. Zimmerman, about, your different, the weight of the walker, those are things that you can build in by process to come in. But I think we overlay that with the idea that the demographic isn't always the one of focus. You know, like when you see a TV ratings thing, it's just like, oh, they got the 18 to 35 demographic. That's the focus for all advertisers and those type of things. So we have that type of disconnect. Are there ways that health literacy and that the outcomes can potentially incentivize the research and the focus within the group?
One of the things that because ARP is really about 50 plus, one of the things that we've really been focused on, so we have our nonprofit side, but we also have our for-profit side as well. And one of the things that they've been really focused on is trying to disrupt the industry. So really making sure that these manufacturers, these companies, these businesses are seeing, how much of a big component and a big spender the 50 plus is, and then seeing how, if they design products with that population in mind, how it can impact their bottom line. Because we found, while we definitely would love for people to do it because it's a good thing to do, if it's not bringing in money or revenue, they're just not going to do it. So really having them, and then as a part of our model, really putting the people who we think will use these products as a part of that pipeline, making sure that they are part of the discussion. Does this really work for you? If you're talking about like, oh, I think all 50 plus are going to use this app, did you actually ask them? I mean, did you actually have them a part of the focus groups and that kind of conversation? So really making sure that people understand the value of really reaching out to that population, and then making sure that that sort of feedback loop is built into the manufacturing.
Thank you. Yes, Marianne.
I don't know, but I wonder, is it because my example was about the supplier that bought out the good supplier, and I fear some consolidation of groups wanting to consolidate, and we offer everything, which I wonder, then there's going to be fights, and the patient is going to be left with one here, one there, and there's still no consolidation. One of the things that is happening right now, as this change has been made to try to make it work, is, for example, my oncologist put one of his staff to work with that group, the visiting nurses, the infusion center, and the patient, to find some way, almost workarounds until they are able to work into a system, I hope, that will make more sense. Because my feeling is, bottom line seems like it means one thing to the higher ups. This is, my go fight them, and a different thing to working level. And so there's some linking back and forth that way that needs to happen. I don't have an answer, but I've seen that as the start to try to push up the system to get it to work better.
Thank you. Steve?
Yes, thank you. Steve Rush, United Health Group, member of the Roundtable. And what I heard is a number of things today, in that our healthcare system is extremely complex. It certainly is for lots of reasons. It gets even more complex as we get sicker, and even more complex as we get older. The cognitive burden that occurs throughout the entire process is magnified as we get sicker and we have less capability to process information. So Michael Valère just talked about, there's this kit, senior kit, that provides a resource for people to look back to. That's pretty cool. And then Yolanda talked about videos. That's another way of getting information to people. And if those videos are available on a repeat basis, that becomes a frame of reference so that the people could go back to it and back to it. So those are interventions that we've talked about in health literacy for a while. And then there's this piece about making language more understandable. We've been working on that too. And that's a real big issue. It's the challenge to that. But testing it out, that's part of health literacy. Doing shared decision-making, co-decision-making, involving people and their families in the process. Those are things that we've been working on also. And so I applaud this panel and then the panel today for talking about those things and reinforcing the kinds of interventions that we've been working on for a while. So thank you.
Michael?
I did want to make sure, Cindy, Brock, if you had a comment, there's only a couple minutes left. I'm happy to cede my couple minutes to you if you'd like.
Technically, we have about 15, so you're okay.
Good. So this is this has been a very interesting discussion today. Much of the discussion has been around older adults, what are older adults' needs, what can we do for older adults, and that. I was interested in kind of flipping that a little bit and hearing about volunteer opportunities or engagement opportunities that would be sought out from older adults. One of the things we do in La Habra is bring together older adults who wish to connect and have them read to children. I remember back in the days when I used to work for the Critical Care Nurses Association, the NICUs used to bring in seniors to cuddle, to put it in the vernacular, crack babies, babies that needed to thrive, to be held, but their mothers were incapable of doing that. And I'm just curious to what extent, and I'll put this question to Marianne and also to Susan for what you might have heard, but anybody please respond. How do you feel about your wanting any kind of opportunity to engage with the community, to contribute, to give back, and how important is that, and how does that fit in with your, with your lifestyle and what have you?
Well, that in some ways is the whole purpose of Silver Spring Village. And we have members and volunteers. A lot of the members are volunteers. The volunteers can be for administrative things or direct services to other seniors. As the organization has evolved over 5 years, one of the things that we found with members is some of them do want other kinds of volunteer activities. And so we have made linkages with several other groups, like Shepherd's Table, which does food, and we take, I think it's every 2 weeks, a meal and take care of preparing it and serving it. And with Easter Seals, which has a daycare, adult daycare and youth daycare, again, do reading for children, and I think also adults. I say it that way because I'm the expert on using services more than providing. I'm more on the administrative service side rather than direct service. So it's sort of evolved as we found out the needs of seniors, and some are happy to help each other, others are happy not to, and so it varies.
I heard a lot about, and Marianne mentioned this earlier, having a sense of purpose and the importance of that. Lillian, 95, worked till she was 85, teaching in a public high school, and in the remaining 10 years is really been struggling with where does she fit in. She's someone who has given back to the community her whole life and has not found that role for herself. She's busy, she's doing things, but she hasn't felt like she's got a place. Ilsa is late 80s and a nurse. She goes to the senior center once a week. She is certified to do arthritis exercises. So she goes once a week to lead exercise for 12 other seniors. She needs to take the accessible van to get there. It's 6 blocks away. She can't walk there. Once she's there, she's got a really important purpose. So it's something I think that's really key, and there are a lot of creative ways to do it.
Yes, Larry.
Yes, hi, Larry Smith again. So the one thing I think we left out of the discussion today that I'd like people to maybe react to is the title of this is Health Literacy in Older Adults. And it seems to me that every older adult, the number one reason they will no longer be able to be health literate is cognitive decline. And then if you combine that with a serious chronic illness, it's even more likely. So where is the role of clear-cut, advanced directive discussions, documentation, making sure that the caregiver, who ultimately may be the healthcare proxy, understands their job is to decide based on that person's values, not their own values. Because I think we kind of left out something that is really critical, because if we don't get advanced directives while a person is still capable of being health literate, it's too late.
How do we break that silence you're really asking? Any reflections on that?
That is sort of the first question every doctor asks if I have. And it was one of the early things that the village started offering every couple of months programs around, I call it health education and related things. The first thing we did was something on estate planning, which is where all those documents can get developed. And we try to offer most of them to the community, not just our members, to, again, get information out to people so that they can take the actions they need.
So I've started to see groups pop up to help address that question, and the name of the group is escaping me right now. But the way that it's to serve that purpose, but to have the conversation in a very fun way. So that it doesn't, I'm sorry?
The Conversation Project?
No, this is something different. So I think people are more and more and more aware of it, but I think we've got a long way to go. Just like people put off doing a will. I mean, and kind of to Lori's question from before, what can be done? What really needs to be done is that you need to be thinking about this at a time that theoretically it's not a matter of concern. So really, when should it be happening? When you're in high school or college. It's really when it should be happening. How are we going to make that happen? But I mean, it's also getting better. Just what, like in healthcare, you went through the whole period of time where everyone had to do the pain scale. Like what's your pain, and to your point, whether or not you had pain or not, right? To make sure it wasn't skipped. So you start to hear more and more within a healthcare setting. Do you have this? Do you have this? Do you have this? Do you have this? Now, is it done in a very meaningful way? And if you say no, is there someone there to then take you and say, to have the conversation about why it makes sense and what the next steps are, and here's a resource? There's still that gap, but it's starting to happen.
Okay, Bernie, you had a comment?
Larry, let me ask you a question, since that was a very perceptive question that you asked. How do you address that in the medical school? Meaning that you have a very innovative educational program at Northwell, and with no real classes. How do you address that important issue that you just raised?
So we teach the communication skills using a very high proportion of standardized patients with videotape review. And there are many, asking people for advanced directives is one of the standard exercises that every student does. Just like saying the word cancer and telling a person they have cancer, and forcing them to use that word and not to use all the euphemisms that talk around what the real diagnosis is. And then we ask the physicians that they work with that when such a conversation comes up, to ask the patient for permission for the student to be there. And I would say that the majority of patients, believe it or not, say yes to that question. Not that we want the student to do it, but to be part of it and to watch a physician with a good relationship with a patient have that conversation.
Great. Well, thank you very much. I know that Bernie is eager to move on to the roundtable reflections of the day. But again, thank you to this wonderful panel, and thank you for sharing your perspective.